Do you know the difference between palliative care and hospice care? You know, I didn't either before I did this interview today, but I think it's really important to know the difference because one day maybe you or a family member might need to take advantage of one or both of those services. Stay tuned because our guest today is going to explain the differences. Stay tuned. Hey, good morning, everyone, and welcome to Scan FYI. Here we are again, Mary Beth.
Good morning, Andrea. How are you today?
Oh, I'm good today. I'm good.
Good.
I'm very good.
Good morning. Well, we're happy to have with us today Dr. Holler of the VNA. She is the Chief Medical Officer of their advanced care. So good morning, Dr. Holler.
Good morning, Dr. Holler. Thanks
Good
for
morning, Andrea, Mary Beth. Thank you so much for having me this morning.
Our pleasure. Of course, a quick shout out to the VNA, who is one of our best supporters, and we always love to talk to folks from the VNA. How to get that out there.
So Dr. Holler, why don't you tell us a little bit about what you do for the VNA?
So I am the Chief Medical Officer for the Advanced Care Institute, and the Advanced Care Institute has many opportunities for patients and families to receive care. So we have the home visiting physician program, which is home primary care. Doctor will actually come to the house to visit the homebound or the medically frail patient who needs, good medical care at the place where they are, rather than try to get ambulance services or rides, those types of things.
Right.
The other branches of the Advanced Care Institute cover hospice care for those patients who potentially an illness has led to the last 6 months of their life. And then we also provide home palliative care, outpatient palliative care, and palliative care consults in the hospital.
Okay, so I think our next question is going to be, tell us the difference between palliative care and hospice care.
Yeah, I
So
think that's going to be
that is such a good
out
question because it continues to stump not only patients and families and the general public and the media, but also large segments of the healthcare provider population. So doctors, nurses, nurse practitioners really still grasp with what those and grapple with what those definitions are.
Mhm.
So palliative care is for any patient who has an illness that is compromising the quality of their life. So palliative care can get involved very early in somebody's illness. Say they have congestive heart failure, they have cancer, they have liver disease, they have renal disease. And palliative care really can step in to help them live their best life. So under palliative care, you want to explore what is compromising this patient physically, functionally, medically, emotionally, spiritually, what's going on in their social circle, family support system, what's happening in the spiritual community. Do they even have a spiritual community? Really to take a 360 look at that patient and who their unit of support is. And help deal with the physical symptoms, of course, of pain, shortness of breath, nausea, vomiting, anxiety, agitation, all the things that accompany people with serious illnesses.
Right. But you're addressing mind, body, spirit here. You're not just addressing the physical.
Correct. So let me just drill down a little bit the difference between palliative medicine and palliative care. So palliative medicine is somebody such as myself, a physician who specializes in palliative medicine after a residency of many different choices people have: internal medicine, family practice, emergency medicine, and then subspecialize in palliative medicine. So we deal with the physical symptoms that patient is experiencing. Also could be a nurse practitioner, a physician's assistant, people that have advanced training in symptom management. Palliative care is a team approach to dealing with all the facets that illness has, how that illness has impacted a patient and their family. it can be devastating to have an advanced illness or chronic illness financially, emotionally, spiritually. People are very used to, having elderly parents that are well and up and around, particularly in Ocean County. The parents have moved down here to retire. The children are up in New York or North Jersey. And then all of a sudden, a serious illness presents itself. How can we help that patient live their best life? Now, on the continuum, hospice is palliative care in the last 6 months of life. So anybody that has a serious illness or has a chronic illness, palliative care is appropriate for them to kind of deal with what questions might come down the line that you would need to decide what's the benefit to you and what's the burden to you, and make decisions about how you feel about going back and forth to the hospital. How do you feel about being on life support, having CPR versus passing away naturally, peacefully, being in your own home, being in a facility, all those questions that may come up down the line as illness becomes more advanced. So when illness, then we have the indication as physicians that, gee, maybe we're in the last 6 months of this person's life, then palliative care is hospice. So hospice is palliative care in the last 6 months of that illness.
Is there an assumption with palliative care that you're going to get better?
You could definitely. So the difficulty, and before when we were talking about like people have struggle with the definitions. So people think palliative care and hospice in the same breath. And that's why people are like, oh, he's not ready for palliative yet. And I'm like, yeah, he is. He's been in the hospital 6 times and he has congestive heart failure and he's got some renal dysfunction. So his life expectancy might be 2 years, 5 years. But people confuse the definitions and they think palliative and they think hospice. So palliative could be like the most, relevant example, I think, is somebody with cancer who's going through all the treatments. And the goal is, say that cancer, the goal of the treatment is cure, not to control. So there's 2 reasons we give chemotherapy: to control the cancer or to cure the cancer. So say you're in a cure situation, but symptoms are preventing you from getting the full treatments or enjoying the time that you're not getting treatment. Like you feel so lousy in between treatments that you're just like, oh, I don't want to see the grandchildren. I don't want to be around my own children. Like I'd rather them see me up and around and healthy looking. So palliative care is for anybody that has any type of illness that's impacting the quality of their life. They don't have to be on the trajectory of, gee, you have this illness and it's probably going to lead to your death. Like you have a serious illness that is compromising the quality of your life. Palliative care can be an adjunct to all the treatments that you're getting as from, the other specialists. Somebody could be on the heart transplant list. So that's obviously a goal to cure, but they're struggling with shortness of breath and weakness and fatigue until they get that heart transplant.
Well, thank you for really an excellent explanation, because I think for me, it was very different than I first realized. I was probably one of the people who lumped them somewhat together.
You and physicians and most of the public, because there's times when physicians say, oh, I'd like you to see this patient, but they're not ready for that yet. And I'm like, yes, they are. Because everybody struggles with those definitions.
Yeah.
So I think palliative should be almost looked at as a positive experience, right? So you want that positivity in your life. So, it's okay to seek it out. And how does one seek that out?
So there's a variety of ways that people can access palliative care, regardless of where they are or which health system they're attached to or familiar with. Their primary care physician can, not even in the hospital, And we've gotten a number of referrals from primary care, family docs that refer to our palliative program. For us to go out to the house, one of the specialists could, in conjunction with the family doctor, refer to the program. If the patient ends up in the hospital, and then the ER, the ICU, a number of physicians and services will refer the patient in for a palliative care consult while they're in the hospital. During that consult, we want to kind of establish what the goals are for this particular patient. So the goal for one patient might not be consistent with the goal for another patient. So when you take off the table, because the first goal that every patient and family, has, oh, we want my mom to live as long as she can. So that's everybody's goal. We want that too for her. But when illness gets advanced, and that's not possible to offer you, what would be important to you? And those are the type of things we want to talk about. And I'll always preface a consult when I sit down with a patient or a family and said, it will not help you if I don't tell you the truth. So if somebody says to me, a number of years ago, I had very active, healthy senior citizen. She was 88 years old. She rode her bike every day, went for walks, and suffered really a catastrophic stroke. So we all know strokes. We see people, talk a little bit funny maybe, or limp, use a cane, a walker, or whatever. And, that's your regular stroke that you see. But catastrophic stroke really took this woman out. So when I said, what's the goal? And the son said to me, oh, my mom rode her bike every day. Well, if I said to him, okay, let's get her to rehab and let's do this, and that wasn't going to be a practical goal for this woman. I mean, she had been, in addition to the stroke, then, renal failure and heart failure and like all kinds of cascade things that had happened during that hospitalization. So it wouldn't help if I just took them by the hand and said, yeah, that's a great goal. Let's aim for that. So I might say, like right now, the goals we have to think about, more short-term, and then talk about what the long-term goals are. So short-term, would she want a feeding tube? Would she want to be hooked up to life support? Like things that are more immediate to the situation. And then talk about the bigger goals. Like how would she, if she was sitting at this table, what would she say her goals were? What would be important to her? And then it could come out that, she loved having the family for Sunday dinner, and she loved cooking, and she loved baking. And if those things weren't in her life, how would she feel about the loss of those key functions for herself and her family? So palliative, when we have a consult in the hospital, unfortunately, a lot of those conversations and the hospice conversations start to link together, which is like a self-perpetuating problem then, because people think palliative and hospice, but the touch point with palliative sometimes is so far down the illness pathway that it does become an option for care for the patient to discuss hospice also.
Can I just point out, this is another reason why it's important for everyone to have some sort of an advanced directive in place and let their family, what do you want? Because if you don't tell people what you want, you're going to get what they want. And that
I think the other thing, and this last year, like facing the pandemic, this has brought this conversation so to the forefront.
Yes.
Because I dealt with obviously very young people, middle-aged people, very old, and it was amazing to me that somebody could come in, healthy senior citizen, okay? So, but still in their early 90s or so, and you say, well, when this day came, when you discussed it with your family, what did they say? And I was like, oh, we tried to never talk about it.
We never talk about it.
So I always tell, like when I speak to the public or I speak to physicians, I always tell people, not talking about it is not going to make it not happen, and talking about it is not going to make it happen. But you're going to put yourself into some type of crisis mode for yourself or your family if you don't talk about it and normalize the conversation ahead of time. I mean, when you think about the planning we do as families and as your unit, your social unit, what are you going to wear? Oh, are you going to wear makeup or not wear makeup? Is it a dress up or is it dress down? Can I come casual? What are you going to bring? Oh, I'm going to bring this. 2 weeks of planning to get together for a potluck dinner. Just say
Right.
something easy, or Thanksgiving, or some other holiday that we celebrate together. And then something as important as, how do you feel if you can't make decisions for yourself? Who do you want to make those decisions for you? If that person is going to make decisions, what would you want for yourself? If your life truly was coming to an end, do you want to close your eyes and pass away in your own bed? Do you want to be in ICU? Do you want to be in the hospital? Do you want to be in a 24-hour care facility? What would be important to you? Because that day is going to come for each of us.
Yeah.
And I wish I could say, like, gee, my own sister passed away when she was 32. And I said to the doctor, I think, this is 26 years ago, I said, I think we have to talk about hospice. He says to me, she's way too young for hospice. And I go back to that moment and I just think, one, I should have fought for her. And I felt like saying to him, like, I wish age was a criteria, because then I could be like, oh, thank God she's 32, so she's not going to die.
Right.
But the pandemic really has put front and center, like, people you would never expect to be in the situation they were in, and multiple family members in that situation. Like a wife telling me, save my husband because my son just died in Staten Island on Saturday. And having to say to her, like, the son was in his 60s, the dads were in their 80s, like, like having those conversations ahead of time, regardless of where you are, just come out and normalize the conversation. We should not be so afraid and death averse in this country to talk about it. If you don't need it for 35 years, God bless. That's what we all want for you.
But it's much better to have that conversation when it's not in the heat of the moment.
Yeah.
Right. And when people say, well, if my dad was here, he would say he wants to live. I said, well, I want him to live too.
Right.
I want him to live. But if the worst happens, we need a map. And we need a road that we can follow that makes sense for him as a human being. As a doctor, I can keep doing things to you. In the end, will they be for you? Probably not. So the end is this. The end is the same.
People
but
who are
how
listening,
you can,
if you
right?
get
How you make.
if you get nothing else out of this conversation today, I hope you will get
Have
out
that
of it the fact
conversation.
that you have to make that plan. You owe it to yourself, and I think you owe it to your family. So you know what, Dr. Holler, thank you for even pointing out the obvious, but that's a pretty important thing to talk about. Now, before I forget, I do want to mention that you are celebrating, well, the VNA Health Group is celebrating the fifth anniversary of its palliative program at Community Medical Center in Toms River, Ocean County. So what has that been like? Because you are the director.
Well, that has just been just a wonderful experience to partner with Community Medical Center on the last 5 years journey. So they did not have a palliative program before early 2016. So February, March was our first consult there, educating the physicians, educating the bedside nurses, educating the public, going out to meet and greets at different libraries and senior groups, and then re-educating everybody again. Because I always said there's like 3 groups of physicians. There's physicians that are on the bus and they're like, thank God we've needed this service for a long time. And there's people on kind of standing by the bus and saying, I think we need it, but you got to convince me. And then there was 3rd group that was like, we don't need the bus at all. So, and that's normal. I worked at the Virtual Health System, the Lourdes Health System, and the Kennedy Health System at the genesis of all their palliative programs. So that's a normal progression for any program. And then to slowly work with providers and patients and families to, embrace the service, see what we can bring to the bedside. our skill set is more having, like, of course, all the critical care and all the medicine background and everything is necessary, but really being able to sit down and spend an hour, 90 minutes to explain to a family how this relates to their particular individual family member. And just to see the nursing staff, respiratory therapy, everybody kind of embrace what we can bring to the bedside. So since early 2016, then we then added a second physician, Dr. Seema Varma, who actually is quadruple board certified. I'm internal medicine and palliative, and she is internal medicine, palliative, hematology, and oncology. So she brings a really distinct, wonderful skill set to the bedside. And then just recently, many thanks to the Grunin Foundation for their support, we've expanded our outpatient program and added a nurse practitioner. So she can follow the patients in subacute rehab centers in their home who are discharged from the hospital to help manage the symptoms and continue the conversations as an outpatient, and hopefully avoid, unnecessary terminal hospitalizations for patients that we see, unfortunately, too often.
Now, this program is at Community Medical Center in Toms River. What other facilities in Monmouth County
So we
a
have
similar-
a physician at Monmouth Medical Center, Dr.
Okay.
Shira Goldberg. Dr. Vandana Sharma takes referrals to the outpatient for Monmouth and Northern Ocean County. And Dr. Vikranta Sharma, I know that's a lot of Sharmas, she is our lead physician at Central State Medical Center. So we have a lot of the facilities covered.
Yes.
That we're in partnership also with RWJ Barnabas. So some of those facilities are RWJ Barnabas facilities. But wherever your listeners live, Hackensack Meridian has a palliative program out of their facilities. The Atlantic Health System out of their facilities. So, yeah, so palliative is getting a foothold across the state. There's growing programs, growing providers, and there's a much better understanding over the years. When I started in the field in like 2007, it wasn't even a specialty then. It became a board certified specialty in 2008. So those of us who were in the field, like, in the beginning, we were kind of beating a drum.
The pioneers, you were.
Yeah. And then it became a specialty. So now, those first 5 years, we were getting board certified, starting fellowships to train the next generation, those types of things. So it's a growing, expanding field.
So now that we're more aware of what the differences are and how important it would be to take advantage of the services, I think that we would have to agree it's a great community resource. It's great to know about it. And you know what? We have to give a shout out to Dr. Shira Goldberg, because she has been such a fantastic scan supporter over the years. And I know she works for the VNA now, and you guys are lucky to have her.
Yes, we are. We are. What I have to say, in addition to Dr. Goldberg, we have a very deep physician skill set pool to draw from that are employed by the VNA. And that's a real credit to the vision of the VNA and to see, there's such a shortage of these types of physicians. So for us to have 6 board certified, physicians working throughout the state, we have physician Dr. Audrey Radin up at Newark Beth Israel, along with 2-3 nurse practitioners up there. I mean, we're very, very lucky to have the depth of talent that we have at the VNA.
Very good. Well, shout out again to the VNA.
Yeah.
We're big fans at SCAN of the VNA. So, and Dr. Holler, thank you so much for being our guest today. I think we all learned a lot, And as we always do, we'll put contact information for the VNA and Community Medical Center in our Facebook and our YouTube comments, all right? So again,
Great.
thank you.
Thank you so much for having me as a guest.
Our pleasure,
you.
our pleasure. And remember, if it's important to you, it's important to us. I'm Andrea Tarr. We'll see you next time on Scan FYI. Bye,
Have a
everyone.
good day, doctor.
Bye.
Bye.